House Healthcare, and we have with us Dr. Elliot Fisher to further educate us on our healthcare system and some of the pitfalls ahead, or the divergent roads.
Do whatever. Yes, exactly.
Robert Frost.
Sure. Well, first, thank you so much for having me with you. It's nice to see you all again. We were all together a month or so ago when Chris Kohler was here, and we were both in front of a slightly larger group. It's great. We'll have some time. As Steve was, I'm totally open to interruption. Just stop me at any time. Some background on myself, if that would be helpful, just to remind you, all of you probably said some of it before. So I came to medicine because I drove an ambulance after college when I had no clue what I would want to do with my life. And drove an ambulance in Somerville, Massachusetts, which then, you know Somerville, Doc?
I guess I do.
Did you grow up there?
My family's from there.
Your family's from there.
Hijacking
An ambulance, no.
So I picked one of them up, who knows?
Inside.
It was, I grew up in a fancy near Brattle Street house in Cambridge, the shisty part of town.
I'm very familiar with that.
Not on Brattle Street. And a mile away were some of the poorest people in the country at that point. And the healthcare was worse than anything I had experienced as a child. Kids were dying of diseases that none of my classmates had. And I decided, pretty much then and there that I wanted to do something about that, which of course, this naive 20-year-old in 1974. And I also thought, God, it would be really fun to be a doctor. Because when you're on an ambulance, most people make it all the way to the emergency room and survive. And you think you did it for them, right? When eventually you discover it's a resilient human spirit and physiology to keep people alive. We don't do that much, except we do more and more now. And that was a great conversation earlier about it. And so I was lucky to go to medical school, lucky to get a bunch of support for training afterwards about health policy and research. And I came to Vermont because first I had family that lived in Norwich and spent time in the 60s with them. And this guy, Jack Wenberg, who you didn't hear about specifically, but the first guy to study variations in the country, was working at Dartmouth, and he had written a very important article that everybody still points back to, although now many people have forgotten, that showed that there were tenfold differences in the rates of prostatectomy or tonsillectomy across the state of Vermont. And if you're reading that as a first-year medical student, you go, I came to this because medicine is scientific, right? This is based in science. We all know exactly what the right thing to do is. And it just shook the foundations of what the 12 other kids and I in this medical school class were thinking. How could it be that these people, all of whom had gone to medical school, were now practicing in such different ways? And, so I wanted to go to Dartmouth to work with Jack because he was obviously crazy. But I think I spent 40 years working with him, helped launch the Dartmouth Atlas of Healthcare, and then spent most of the rest of my life trying to figure out why can't we perform the way we should be able to? There's some summary lessons that I don't have in the talk, but I think they point, Steve, to relevant things for why it's so hard. First is, we have inadequate evidence. There are so many treatments that we provide to patients for which there is not great, sound scientific evidence. It was much worse back then, but the strength of the evidence isn't great enough to constrain your decision-making narrowly. There's going to be judgment about it. So that was really the first insight of that work. It led to all sorts of efforts to do comparative effectiveness research. The Patient-Centered Outcomes Research Institute sort of came out of this, that we need to know the outcomes before we can tell someone what they should get or not. The second thing that came out of the work with Jack which should resonate at least, is that people differ in what they want. They differ in their preferences. You know, some people want everything done at the end of life. Some people would rather have hospice care. Back surgery, you know, the first time I was offered back surgery by an orthopedic surgeon, I said no and managed to get by for another 10 years. First time I was offered a joint replacement, same thing. Oh, your joint looks horrible on the x-ray. I can replace that for you. But no one really offered or thought much about until Jack came along and showed these differences. Well, there are risks and benefits to these things. You know, if you think about mastectomy for breast cancer or the different treatments for breast cancer, women feel different ways about each of the options that are offered. And so that was the second insight of our work. And then the third insight of our work was most of spending differences across the country, and they differ by a factor now 5 in the most recent data, are due to how much care is provided, nothing about the patient. It's not how sick they are, they get more care. It's not whether they really want the care. It's that we have a system that is designed to deliver care. And once you give us a hospital, once you double the number of specialists in that hospital or in that town, or they keep themselves busy. So we have huge differences in spending, and that's really been the focus of my policy work since that aha went on, and we compared. I'll show you a picture of the work, but basically across regions of the United States, there's threefold differences in per capita spending. There were, after adjusting for everything we could and identifying identical people to track over time, the people in the high and low spending regions, the people in the high spending regions did not get anything more of the stuff that we know is evidence-based or good to do. They didn't get more beta blockers. They didn't get more treatment for diabetes, better treatment for diabetes. They didn't get more major surgical procedures. Surgeons happen to want to live near Alta. So surgeons, orthopedic surgeons locate themselves where there's good skiing, slightly unfair, Vermont. But the decision-making of physicians is driven by the patients in front of them. It's not based on shared decision-making or evidence, in large part. Evidence is really important and it makes a huge difference. And Steve was absolutely correct that in diabetes, we are doing much better than we were before. We are still failing to treat diabetic patients correctly half of the time. Half of people with hypertension are not well controlled. So the opportunities to do better just abound in healthcare. Oh, I didn't tell you what the differences in spending were. It's how much time people spend in the hospital or how many times they see physicians. If you ask a primary care physician in the United States, as we did, we surveyed physicians all over the country trying to figure this thing out. So when would you see the patient with well-controlled high blood pressure and no other medical problems? This is a very simple case, right? Medical problems. I won't ask you. When would you do it? It ranged from 1 month to 12 months. In Miami, they'd see them every month. Most expensive place in the country. Callan, Texas was right up there by that time. In Oregon, it was every 6 months or every year. So the policy work was around what can we do about that? How can we try to think about all of the ways that we could improve the performance of the US healthcare system? So that's background on me. That's the big insights. And what I really wanted to do was to try to reassure you that I think you are in a great place. It's hard to say that having looked at what UVM is doing, that $800 million we just learned yesterday that they took out of commercial ratepayers, and we don't know where they put it yet. But we have a great opportunity. We have the strongest state regulatory agency in the country, the one with the most authority to do things. It can control all provider prices. Mike just helped me look it up. They can control professional fees. They can control hospital fees. So on the service delivery side, they can put firm constraints on what the prices can be. They have all sorts of other tools. They're allowed to do payment reform. What they don't have, they're missing some tools And that's the bill that you guys are going to struggle with that comes over from the Senate. What tools should you give them? But they have a lot of the tools they need. They don't have the resources they need to do it effectively. So what I thought I might do is, first, the one part was we have a great board that has potential. The second is we now have a wonderful burning platform, right? Everybody is really angry. Everybody is paying attention. No one can think and look at their premiums or look at the graphs that someone will show you and say, oh, this is, school boards are struggling, property taxes, and I think we're ignoring, the attention to education costs, I think is really misplaced to some extent because it's being driven fundamentally by our unwillingness so far to control healthcare costs. So be hopeful, but let me start with the harms are worse than we think. How about that? So, but I was reminded that sometimes I get geeky and just make this very detailed argument. And I've been reminded by friends, Ellie, you got to say things 3 times. No one's going to understand you the first time anyway, because you're too complicated. So this is the gist of the argument. We have a crisis of affordability and access and profound economic harm. And there's growing data on that. We know the largest driver is Vermont hospital inefficiency, but it's made worse by primary care, by inadequate access. We sort of got this horribly imbalanced system where I think, the Rochester experiment, Tavir, is a wonderful example. They said, well, let's not let the hospitals grow. Let's figure out how we create primary care systems that can take care of people outside the hospital. And we had Act 167 report, Bruce Hammer saying, and you guys should do that. So hospital inefficiency made worse. The potential savings, I think, are huge, and I'll argue for why that is in a second. That $800 million stands out as can we get that back? Didn't you guys pass this wonderful bill that said they can claw back that stuff? I think
You
so.
know about that.
What? Oh, you didn't know about it? Yeah, no, you guys, this is great. I mean,
More like gently take it back.
sorry?
We're gently taking it back. We're not.
No, it's got to be gentle. You don't want to, it's a very important institution. We need, anyway. But huge savings, I believe. And I'll make some arguments about that. But these are the 3 things that I didn't really realize for 40 years. For 40 years, to what degree they were causing our inability to solve these problems. One is the balloon problem, which I'll come back to. I mentioned it when we were all together. The second is market failure. And the third is that special interests show up and the rest of us are kind of distracted by having to do our day jobs. It's formally called the collective action problem if you were in political science. So special interests get their interests represented. And I think we're seeing that writ large now in American public policy as I wake up with nightmares every night. But solution really is strong and aligned state agencies, which can address all 3 of those. And I want to try to persuade you that that's what the fundamental thing that this bill is about, and can be strengthened. And you have to think further how to make it more so. But it is, how can we make care better and cheaper through planning and evaluation across the system? And if I were echoing what I just told you at the beginning, it would be, we need to bring better evidence to clinical care and make sure that our health systems are adhering to the clinical evidence. Great anecdote. Last Saturday, had a little piece in the Valley News that was republishing a U.S. News and World Report thing. Elena Barabay and I published. Got an email from a psychiatrist who said, White River Family Practice, we've eliminated hospitalizations for our patients for behavioral and mental health conditions. What share of hospitalizations are for mental health conditions or exacerbated by them in the United States? It's a huge share. And they did it by implementing evidence-based practice across the whole practice with occasional consultation from the psychiatrist who emailed me. What if we spread that across the state? So better evidence, And that's planning and evaluation. How are we going to do it? What's missing? Which places aren't we doing it? The second is regulation where needed. It would be wonderful if we had a competitive market here, but you all made it very clear we don't. We don't. And then I think the special interest show up thing is why we're struggling so much in the United States. And it is a real problem for anyone trying to change policy. Because I don't know how many phone calls, how much time you spend with lobbyists, but when I walked in last time and asked, how many lobbyists are there here? You may remember, I think it was 567 or something. So I think I'll come back to why we need independence and accountability. All right.
Can I ask-
Yes, please, of course.
I looked ahead and if it is coming, it's not coming anytime soon. So
Okay.
I want to ask.
Jump in, sure.
Yeah, you said something about, like, just rewinding a little, you were talking about reinvesting.
Mhm.
And you said, like, why can't we do that across all of Vermont? If we did that across all of Vermont, but there was still other barriers like cost sharing for accessing primary care, I would guess it wouldn't be as effective. It would improve things, but it wouldn't be as effective. But what if we did that across Vermont and gave universal access to primary care?
If you could do universal access for primary care, it would be my first next wish for something this session would include in the bill.
Thank you.
You'll see it on my final slide.
Have you, by chance, have you seen the bill up there about the incremental implementation of Green Mountain Care?
No, I haven't. but
Okay. Yeah, if you could just look at it and we can talk another time, or maybe even come back if we ever take testimony on it, but it would just be, I'd be interested to hear your thought about that approach. All right.
I mean, what I think you'll hear from me is, and to do any of this, you must delegate through someone who's going to do the planning and implementation and bring it back to you so that you have a better chance to make a good decision rather than designing it all yourselves and setting all the rules up in legislation.
Okay, thank you.
So Health Economics 101, are we getting value for money? Answer, no, right? Compared to other countries, they spend half as much as we do and get better results. And I look at that graph and say, well, that's potentially avoidable spending. That's waste. Question?
Yeah.
I'm just thinking, I'm just
Yeah.
thinking about the clinician in the office and how do you get from the avoidable spending and waste into the,
We got to get there.
yeah,
We got to get there.
because that's hard.
No, it is. And I see, and yes, it is. So the direct harms of rising costs, I don't have to explain it. We know what they are, although I was surprised when I went and sort of dug into it. Primary care access has collapsed in the United States with 100 million Americans estimated to lack adequate access to local primary care, twice what it was in 2014. And you probably know it's similar in Vermont. People are going to, if you ask how easy is it to get care, it's going to have gone down. 1 in 4 Americans have death due to medical care. Didn't realize that 40% of those, it's a visit to an emergency room that causes that death. And 3/4 of us worry about being able to afford health care. And that must be worse for Vermonters right now with everything they're hearing, right, about what's coming. Health Economics 101, second point. And this, this is an article I found after talking to you guys before. Zach Cooper and his colleague Zarek Goldberg published this as a working paper in the National Bureau of Economic Research, which is sort of one of our engines of being smart about economics and applying it to healthcare. But very carefully done. A 1% increase in healthcare prices is essentially a payroll tax. And I don't know how many of you are business people, but payroll taxes are known to be productivity killers. They lead to, a decrease in private payroll and employment, decrease in county level income, increase in county unemployment. And their numbers came out quite clear. 1 additional suicide overdose death per 100,000 people. I don't know what the base number is there, but it's probably 40 or 50. So it's a big, substantial health impacts and I love their quote. you know, because it kind of tends to apply to what I think we see with the University of Vermont Medical Center's recent behavior. I don't know if you're familiar with the term rent seeking. It's an economic term for using all the economic power you have to take money from us because you can, to maximize your income. Did someone say greed earlier today? I've written about greed. It's got me in trouble, but I don't think it's why we came into healthcare. I think that's the paradox of healthcare, that so many of us came into this to try to make things better. And what we're causing is suffering. And that's why there's so much moral injury right now. I didn't mean to give you a downer. I'm supposed to be up. This is supposed to be an upper of the talk, right?
It's good to be realistic though, and it makes me feel validated as a healthcare provider that you say that.
Well, I think it's a terrible problem. So, well, if the cost went up so quickly, why can't we bring them down quickly? It's not because people got sicker all of a sudden. It's not because we're delivering so much more evidence-based care now when we know we're no better than anybody else. So if prices went up that much, why can't we bring them down? That's, I think, the fundamental question, which I think we should try to. So I use the term waste there. There's been a lot of work on the sources of waste in American healthcare, and this is going to be very nerdy. But if you look at that right-hand table, and these are two different research groups, but both land at 20 to 25 to 30% of US healthcare spending is waste. And if you talk to, I'll show you another slide from Intermountain Healthcare, but some people think it could be 50% of what we're spending. So the sources of that are failing to give the best care to people, not delivering safe, reliable, and effective care. It's not, you know, if you saw, I'll come back to it again, but it is possible to do these things well and to do these things quickly. It's not impossible. 90% of patients in Kaiser Permanente have their blood pressure controlled. Almost all of the diabetics have their blood sugar controlled. You walk in the door, you get access to an orthopedic surgeon. My grandson had hearing loss at birth, worry about cytomegalovirus, was seeing the San Francisco Bay Area's expert on CMV, congenital CMV, that next day. So the parents did not have to worry about whether their kid was going to be deaf or retarded. Yeah, totally.
For those of us who don't live in California, aren't familiar with the Kaiser delivery system, can you explain?
Yes, good question. Thank you so much. So Kaiser Permanente is one of those, it came out of, I don't think it was the forestry, I think it was the dock workers. It was a capitated system that provided health insurance, health coverage, prepaid health coverage for all of the workers in the industries that signed up for that plan. It is now a fully capitated integrated delivery system where you pay your annual or monthly premium and almost all care is free with some small co-payments. They're an integrated system, so, you know, my hypochondriac daughter can get a phone call in and get help whenever she wants it. And it's, you know, gets a nurse practitioner 24 hours a day, can know whether to take her kid to their walk-in clinic to get their sore throat checked out, to know whether they've got strep and can go to school. And if it's not, then she can leave them in daycare. So it has not spread well. We need to figure out why. There's something about the culture there, and there's something about the culture of American medicine that hasn't let it spread. So not doing the right thing, fragmented care, you know, where people bounce from specialist to specialist and no one knows who's responsible, no one knows who's the quarterback. Overtreatment, there's a lot of overtreatment in the United States, whether it's surgery that patients would not want if they were choosing, or so there's lots of waste, unnecessary days in the hospital because, you know, And then there's all the pure waste, administrative complexity. We should have a single system. Agree with you guys. Monopoly pricing is pervasive in the United States. I'll come back to market failure, and fraud and abuse. So, question, yeah.
I looked at your slides last night and, well, no, because failures of care coordination struck out at me only because we hear in this committee all the time about care coordination.
Mhm.
And it feels as though everyone comes in and is doing care coordination and touts the benefits of their care coordination, to which I'm beginning to think that we have so many care coordinators that our care coordinators need care coordinators.
So I think that, so
Yeah, why haven't we seen, because this has been tried through the all payer model,
You should-
blueprint.
it's really, getting under the hood of what people mean by care coordination is really important. So one kind of coordination is what many health plans do, which is, Elliot, you're sick. I'm going to give you a nurse or a care coordinator to make sure you show up at your appointments, and to keep you out of the hospital. That's some part of care coordination. The care coordination you see in truly integrated systems has strong primary care at the center of it, with a team of people who can help. And the primary care clinician team is coordinating care with the specialist effectively. And the specialists aren't just ping-ponging their patients from specialist to specialist, which happens all the time once you get into the hospital. So I think the opportunity, fragmented care, it'll never be perfect, but there's so much more we can do. I don't know whether that answers your question, Jeremy.
Well, I'm thinking about, we had rigorous HMOs. I mean, speaking of Kaiser Permanente was in the state of Vermont.
Mhm. It probably wasn't with its staff model version that they had out there.
No, they didn't have specialists, specialty care or anything, but they were primary care. But that was the model of essentially your primary care provider referred you everywhere you went, sort of coordinating your care.
And in some,
And then that,
I think that can work. I think I think it's fallen away. I mean, and the ACO was supposed to do that, right?
yeah. Do you think we saw benefits from it, or do you?
I'm sure it was better than chaotic, wild type fee for service practice.
Mari?
I think the blueprint and SASH are great models for how care coordination can be effective. And then I want to throw in there the rise in use of telehealth
Mhm.
for particularly for specific issues. Like, I, as a patient, have an issue and I can't get in to see my primary care provider. So, there's this company that is selling this medication that I've heard about and I think might be good. So I think more people are utilizing these online. And then we've got Amazon, and then, so have you looked at the impact of those yet?
Detail of those. This is mostly supposed to point to, and the numbers are, who can measure things to the 0.9%? At this it's ridiculous. They were making estimates. There is lots of waste in American healthcare. We can do much better. That's the major point of this. I don't want you to get too stuck, although I do want to come back to administrative complexity, pricing failures, and fraud should not be ignored. These are just, I don't want to spend much time on the first one. That was the one that I already told you about. All the excess use in the high cost places is extra time in the hospital and extra visits, mostly with specialists, which are completely avoidable and unnecessary. monopoly prices are terrible. Payment reform can, I believe, and this is the Kaiser's or Intermountain's experience. Intermountain is a healthcare system in Salt Lake, Utah, which also has invested a huge amount, or did until they got a new CEO in 2016, in quality improvement and showed what was possible. And I'll show you a couple of graphs from that, because it was Brent James, the author of that piece, who believed from careful study of everything in their system, which was already one of the cheapest systems in the country, that the total savings, could easily exceed 50% of what we're spending on healthcare if we invest in quality, and get the payment models aligned to support it. So this would just be an example. They in hip replacement, over the course of a year and a half, they reduced costs by whatever that is, 14,000 down to 8,000. So almost a 50% decrease in cost for doing a hip replacement. That's a huge saving that can be done quickly.
Is that by preventing complications?
That's among it's reducing complications. It's reducing unnecessary length of stay. It was cleaning up or just saying, surgeons, I'm sorry, you can't each have your own packet. You're each own instruments. You got to choose the same instruments. You're going to choose the same joint. We're going to streamline the supply chain. If you don't want to work in this, we'll use evidence. You get to help us decide. But once we decide, you're going with it. The same thing with the cath lab. They were able to take, and this is the frequency of cardiac cath labs. That was getting rid of inappropriate caths. We're just going to follow the evidence. We're going to put in place evidence-based guidelines. It's a simple checklist. By the way, it takes care of your pre-authorization. They implemented it. Inappropriate cath rate. The cath rates in the lab overall fell by 22%. So there are all these opportunities which can be done relatively quickly. I think I have and so this was over, I think that's it. Anyway, over time, they were able to take out a lot of costs, and they kept costs in that market, their portion of the market, down to CPI +1, which is much lower than healthcare costs in the States. Go ahead.
I'm just curious, because this was 10 years ago. So has it sustained?
I know they had a new CEO come in.
Okay, so that's what you're referring to.
The new CEO came in just as they fired Brent, closed down, Brent James closed it down. He was on the cover of the New York Times Magazine,
Yeah.
you may remember.
Yeah.
How they closed it down. But you have another example, even closer in Cleveland, that you guys have all, I hope, went to listen to Peter Prentice. If not, you should watch his slides at the Green Mountain Care Board. Because he's done it now. He's done it recently. And so it's the same, this is from his presentation. So we can do this relatively quickly. So the most expensive part of a surgical stay is how long you stay in the hospital. There are lots of fixed costs tied up in that bed. They, in 1 year, reduced the length of stay for surgery from 6 days to 1.8 days, to 2 days. That's a 60% reduction. And they did it for all sorts of other things across their system. When they decided we are going to root our strategy in quality.
What effect did it have on their revenue?
Oh, their revenue's gone up
Oh,
because they've taken out costs. I mean, they were struggling financially. The project is called Medicare Break-Even Project. So they've reduced their costs and they're on track, I think, to make money on Medicare, which they weren't doing before. So that will allow them conceivably to reduce their commercial rates. I don't know what the rate setting is there. I don't know, how effectively or whether they'll use their savings to invest them in some fine hospitals elsewhere. I doubt they will do that.
but even though they're doing less procedures, their revenues have increased because of the efficiencies,
Net revenue.
net revenue.
I can speak on the net revenue. This is the other reason I wasn't looking at my slides, to make the point for Intermountain. Their net revenue declined dramatically. And they had the best financial position of any healthcare nonprofit in the United States at that time. So margins were great, their bond ratings were the best, and they were costing the community less. Now, it may take a regulator to hold them into,
There it is.
to hold them to account. But this was, this is answering the question, avoidable costs. You know, can we do better?
Do they look at post-op complications and readmissions?
Yes, they did. All came.
So
down.
it all worked out.
It's all about improving quality.
Yeah.
And all the rest
Way
of it
beyond
follows
just-
from that.
Numbers, okay.
Daisy, did you have a question?
I did, since you opened the box on that presentation, which I found really wonderful. How is his theory on, really the foundation of quality in healthcare,
Culture?
culture? Yeah, how is that different than the, like, meeting the quadruple aim of healthcare, which has been around for a while? I mean, it felt like some reframing around, in injecting it with love, but
Well, I don't think and I was talking about this earlier with somebody else. I think I can name 5 places, maybe, it may only be 4, where the leadership was deeply committed to the kind of culture change and then systematic application of meaningful, effective quality improvement across the whole organization. So it would be Cincinnati Children's, Seattle, what's the Seattle Hospital? Came up with it yesterday. Cincinnati Children's, Nuka in Alaska, Intermountain, and now Cleveland, University Hospitals of Cleveland. I'm sure there are others, but they're not jumping out. So it does require both. You can't do all the quality improvement without the culture change. And that's why I quote it. I mean, Charles Sorensen is an amazing man. I'm building a case on Intermountain for teaching. He's just extraordinary.
I would add also, if I may.
Yeah, please.
Challenge me if I'm incorrect, but also you must have the resources to implement the technologies to measure the quality, because if you can't measure it, you can't change it,
No,
right?
totally. No,
So that's the other thing I think that all of those places, I'm guessing, have in common.
this is where modern quality improvement is. It's not just about the high technology, and you know from that presentation, and Peter has promised to send me, run charts for all of the cool things they're doing. And they've got 4,000 of them or something like that. That's probably an exaggeration. But once you teach people what kinds of work it is, what's the key, TKOs? You guys are some business, we're some business people around me.
KPIs.
KPIs, that's it. TKOs, that's knockouts or something like that. So, yeah, no, you choose the indicators and then I think that surgical length of stay is a pretty good measure of cost, an aggregate measure of cost, and it's easy to measure. Come straight, you can measure it on a weekly basis. So I don't think it's impossible at all. I don't think it's hugely expensive. Yeah.
I think thank you. I think the culture part of it is so important too. I'm thinking about when the Affordable Care Act rolled out and there were the incentives for hospitals if they met certain quality measures. I think there were 8 of them or 10 of them. And one included patient satisfaction, and how that rolled out in a lot of hospitals was upper management. I'm being a little bit, anyway, literally being given scripts of how nurses were to talk to patients. And one of them, I think one of the hospitals, not in Vermont, used a Disney derived script. So I think the leadership culture is really important because that was not effective.
So
You just made a lot of staff
yeah,
really angry.
yes, there's no question. And I think that's the answer from Intermountain. It's the answer from Cleveland, from University Children's Cincinnati, Children's Cincinnati. And it's the answer from Cleveland. And it's the answer from Nuka in Alaska and Virginia Mason, which is that place in Seattle.
Virginia Mason.
Virginia Masons and.
Virginia Mason. That's the answer. And I think it's the answer at Kaiser. I mean, it's a bigger bureaucratic, more bureaucratic place, but just because I get the eyes into it through my daughter, it is totally patient focused and so anyway, let me keep going so that we can talk about whatever you want to talk about. Although I'm happy to, I showed you this slide before. I don't think, but it comes back to creating a learning system, and it's fractal. So this is what, White River Clinics, White River Family Practice does. They've adopted run charts and process improvement tools across their whole practice. It happens at health systems, at a healthcare organization level, the 4 places I named. And I think it should be the same model of learning and doing systemic quality improvement across our state. And so let's charge the Green Mountain Care doing that. No, we don't. Or let's get AHS to do it. Someone has to do it. So we need data. That's great. And then we need to figure out how we're going to put it in place across the state. And then we need to figure out when savings are achieved, how those savings are distributed between the organization itself, which you want to have it's good for us if they all have good bond ratings. If they need to borrow money, the better their bond ratings are, the better. So, but we want their margins to be on a lower base so we can afford it. So that's where all payer oversight payment. Let me wrap up. Oh no, I meant to come back to this. So why this is, that's kind of, quality improvement, that'll be easy. Why haven't we been able to do it? First is this balloon problem, which I showed you this slide before, but it is really, I think, important. That is, it's so easy to get around the stuff we put on them right now. Right? Public payers let's control Medicaid prices. Hey, we've just seen it in Vermont. You can raise your prices to commercial payers. Episode-based payments, that's one of those fancy ways of making fee-for-service along the bundle. But you can just shift the money out of the bundle. The test that you would have done on week 3 when they set the price, you do the test at the end after the bundle. And that's what they all were doing. So they set the price of the bundle, and then you try to take as much out of it and move it outside, and you make more money on the bundle. Or you just do more of those bundles. ACOs, I came up with that gosh darn idea. And it's not lived up to its promise. But when you talk to ACO leaders, what some of them do is especially the ones that are owned by hospitals or led by hospitals, we'll keep our ACO patients out of the hospital. That's those care coordinators. That frees up all those beds where we can put commercial patients who pay us more. We can make plans, limit their profit, their maximum ratios, blah, blah, blah. Increasing copays and deductibles. That's how the payers shift it to us. So, the balloon problem, market failure, I had not realized just how concentrated hospital markets are. 90% of the markets are monopolies now. Or oligopoly, or 2 monopolies. And lack of competition is not just about prices, because I think we're seeing this in Vermont right now. The data from the country is that you ignore quality. If you don't have a competitor, you ignore quality as well. How long does it take to get in to see somebody? You can raise prices, you can be inefficient, and you can move resources around someplace else without any oversight. The last one is the one I want to emphasize, because I think it's sort of the recent history of democracy in the United States, as we've made it easier and easier for special interests to influence the way the world works. And It's called the collective action problem, as I mentioned before, but they show up and we don't. So I think a strong state agency is the best way to address all three of these. Set total cost of care targets and hit them. This is about planning, learning, evaluating. 15 states now have total cost of care targets. Several of them are figuring out where to set those limits so it doesn't grow any further and how to set them. And I think we should set total cost of care targets that don't go up. They should go down, and we should figure out how to reach them. But we need to figure out how to get there. So that's the planning part of it. So I think you'll notice in the bill that came over, there's a fair bit of emphasis on planning and evaluation. And I think that's really important. The market failure, that's the original reason that these state agencies were set up to deal with monopoly pricing. We should have competition where possible. Maybe that could be among primary care practices. I think it might be a great place to, let people choose who they're going to go to for their primary care physician, primary care practice. That's a place we could have competition. We might be able to set up competition between Dartmouth, Hitchcock, and UVM to say, we want you really to know the cost and quality of these two and make it easier for people to choose, especially because they've got everybody overall, as far as I know, got high deductible health plans now. Could we set up competition there? Maybe with Albany. How do we create competition for the quaternary stuff where we really either we shouldn't let them do it, or if their volumes are high enough that we can measure their quality, we measure their quality.
Can you repeat I'm sorry, can you repeat what you just said?
Please.
Maybe we shouldn't let them do that. What should we not let them do?
I think their quality, both Dartmouth and UVM, probably Albany as well, aren't huge health systems, right? There are some procedures that they don't do often enough to be expert. And it might be that we would be better to negotiate regional agreements where advanced cancer transplants get done at one place, so the volumes are really high. Cancer treatment can stay local, but that would go to one place. I would be encouraging us to think that way. When we get down to our smaller hospitals, and we'll come to that, as we think about the crisis that's facing us now, the whole discussion about what's a hospital that you had with Steve is a great and important conversation. Do you really want to get surgery there? Do you really want to be treated for sepsis there? What should be done in those places? And I think Hammery's report was right on target to think about what are the centers of excellence that would let us have some number, less than 10, real hospitals, and then others that are centers of excellence for other services, whether it's hospice or long-term care or rehab or the regional center for rheumatology, where the rheumatology practice is that you can go. That's where we have to think about that. But that's the maybe we shouldn't do everything everywhere question. And then choice would be for the big, really expensive things, along with this shared decision-making. I think so people understand the real risks, they should then choose the place that's got the lowest risks and lowest costs that they would like to go to. That puts some competition back in the system, and then here, I think whatever agency you decide should be running things, and I think oversight and I'll come to this in a second, single point of responsibility for overseeing and managing the healthcare delivery system, not doing it all, but oversight, should sit in a place that has the following characteristics: independence, transparency, and accountability. I think it limits the capacity of special interest to secure special treatment. I think there's a risk. The more you can have, I just think you need to think about how special interests exert their influence when you're figuring out where you want the locus of accountability and responsibility to lie. I can stop there. Please, yes.
You're from Norwich, you have an affiliation with Dartmouth.
Yes.
So how are things at the hospital at Dartmouth? I mean, do you interact with that hospital? What effect have you had on your community?
There was a period where we had lots of influence, and they implemented we had the first center for shared decision-making in the country. The Spine Center under Jim Weinstein's leadership was probably one of the foremost places where you could go where you would be told you do not need back surgery, and given evidence. Administrations change, and this is why I think public accountability is really important. When it became a bigger network, the question of how to make sure we generate enough revenue, they're not as bad as I think UVM is, but they're still expensive. So I think they've gone from embracing ACOs to rejecting them to now being back thinking they're important. They certainly didn't listen to me when I told them they shouldn't build another surgical wing. God, what a waste. Anyway, just a more unnecessary surgery. But that's and the problem is once you hire one orthopedic surgeon, you have to keep them busy, right?
So what is their mindset? And you give them ideas and they do it anyway.
What's the mindset?
Do they do a study?
Yeah.
That's going to make them money?
Oh yeah, no, we know, I believe this, and the playbook for making money in healthcare is revenue generation. There's very little attention or incentive to reduce cost. But why not hire 2 more people in the C-suite who will help us generate more revenue by building our network, by having relationships and referrals from more hospitals. So let's increase revenue without, from my perspective, adequate attention to whether people needed or wanted those. Or even whether you could reduce the cost as much as possible for whatever services you delivered. So no. What is it? You're never supposed to try to do improvement work in the plate where you're never respected in your neighborhoods. Is that, or elsewhere for that matter. But go ahead.
But you have a point of view.
Absolutely.
You have
Very
ideas.
strong point of view.
You have ideas and we're listening to them.
Yeah.
What others are out there with perhaps a different pitch than you're going?
Yeah, on cost containment, which is, I think, the most acute crisis we face. It's all healthcare leaders should be good people and try to go after the quadruple aim. That's the Don Berwick, IHI. Everybody should try to make healthcare better, cheaper, health better. I think the federal government was very much aligned with the move to value-based payment. And that's a Republican, that was true in the Trump administration as it was in the Biden administration and before. The move to value-based payment is widely seen as the only way out of this, mess. I think that the reason that Chris Kohler joined, writing the paper that I shared and that you, is that states have more authority to herd the cats toward the models that are likely to succeed. I mean, I would, I don't think we need hospital global budgets if we had a really effective ACO or multiple ACOs, because they would, and they were physician-led and not associated with hospitals. They were track owned by, their incentive wasn't to keep the hospital full. Their incentive was to keep the hospital empty. But what other
Today, hospitals are trying to get patients out of the hospital. They're not generally keeping them there because they're not going to make money by keeping them there. Their mission is to get them out as soon as possible. So that argument.
No, I think, well, it's pretty impressive. Yes, that was true, but they don't know how to do it. Just these, we should reduce length of stay, or we should get people out quickly. They don't know how to do it. And yes, the current payment system rewards them, kind of, if they increase throughput, but it doesn't make them much more money. It's marginal that you're doing it instead of a medical stay. So putting the systems in place that allow primary care. So again, Pronavost's system, their ACO reduced costs by 40% for the patients in their ACO, because the incentives are aligned to keep them out of the hospital. So I think it's a combination of incentives and leadership knowledge about what you need to do to improve care. And the latter is the thing that I think is two things: motivation and the leadership capacity to care about it. Because, and then the willingness to try and apply effective modern tools of improvement to do it. I don't know whether that makes sense or not.
But if you try and you fail, that's a big issue.
Yeah, no, you're right. So we need to help. We need to provide coaching. Maybe Dr. Pronavost will come help us coach all of our hospital leaders. I live in a fantasy world. This may not be a
Better to
fantasy.
try and not, better to try in case you, I
It's
mean.
better to try and fail than to never have tried.
Never try at all.
before. Yeah.
I mean.
But still, I mean, there's a lot at stake, our communities and.
I totally get it. I think that the how we put in place, and this is can I come back? I want to do one more slide with you, because I want to come back to you're pushing on exactly what I think the current crisis calls for.
Can I, before you move on though, can I just expand a little bit? Because this is
No.
so I feel like I've seen almost every kind of payment model that there is. Fee for service is bad because it incentivizes too many tonsillectomies. Capitation incentivizes actually not having basically more people than you can take care of, or not seeing your patient. So if it's tied to value, which we haven't really been able to measure value, why have we not at this point accepted what motivates healthcare and what incentivizes care? And why haven't we just exploited that?
What do you mean? Tell me more about what you think motivates care.
Why do we, I'm just thinking, why don't we just throw our hands up and say, fine, this is the psychology of the care that we give now based upon the financial incentive. Why do we not just say, fine, we're going to pay you $1,000 if you see your patient for their diabetes every 3 months, and we're going to pay you $100 to see somebody in the emergency department? Because
I think
you wouldn't,
that's what
Dartmouth wouldn't have built a surgical wing if we said,
I think the notion of trying to align the payment incentives with what we want is exactly the correct way to think about this. I'm afraid, I thought you were going to a place, and I'm afraid that and I think an effective state agency would help you do that, right? So if you think about reference-based pricing, which we could apply on the commercial side. Medicaid might be able to apply, adjust rates up and down to different sectors. You know, we could pay more for primary care and less for hospital care.
Which we actually do, sort of in Medicaid.
And we could do more of it.
Yeah.
If we want to strengthen primary care, which we really should do. So I think the failure to recognize that there is so much room for improvement. And then you say that and people go, I don't know what to do. How am I supposed to improve? I think that means work harder. That's
One
it.
more patient a day.
Yeah.
Remember that
I'll
one?
add one more patient to my panel. That's how I'm going to improve.
That was torture.
But that's not improvement. You know, when you look at what these places, they've all applied the stuff that came straight from Deming, 100 years ago into manufacturing and now is dribbling into healthcare. The Charles Sorensen, who ran Intermountain that time, knew exactly how to motivate all of his clinicians. It was to provide the best care possible. So that's all. So you need culture too.
Well, that gets me back to one of my questions. How do you change practice to the bedside? Because I think from what I've heard, it takes 15 years from research and has that narrowed or?
No, it takes 15 years if we wait for doctors to have read the journal.
Go to their conferences or whatever.
Go to their conferences and then decide to change their practice, but they learned a long time ago. I mean, the guy who was going to do my hip replacement when he proposed it was doing a procedure that everyone knew had more complications than the anterior approach rather than the anterolateral up at the lateral approach. He would have had to learn something new. He didn't do it. So that's the 20-year, let it dribble into primary care practice. If you look at what you will see in Pronovo's presentation about diabetes care or, chronic disease care, which is where causes most of the chronic diseases, diabetes, hypertension, smoking. But you can get those clinical treatments to the kind of standards that KP has set of 80 to 90% in a year. If you use the tools of saying, what is the evidence and how do you make it so the clinician doesn't have to remember that and it's automatically, becomes increasingly part of how the practice delivers care, not because we remember it, but because the prompt comes up.
Epic. You're talking about
Maybe
any form, I'm using example.
Epic may be one.
Yeah.
But then there are all the other things that Epic doesn't do. So that would be one of the little quality improvement things, make decision support. But another would be patient adherence. How do we call patients after, how do we make sure that we're texting patients so they take them? All of the little steps you can do when you have a control chart that shows you, oh, we got a little progress. Let's do the next thing.
Does that remove the art of medicine?
Not at all. Not at all. People feel so empowered. The reason there's moral injury in healthcare is because we are not able to deliver excellent care. I shouldn't say we, I'm no longer practicing. Okay.
You did it a long time.
I did it for 20 years.
That counts.
Sorry to wait.
No. Does that answer your question?
Yeah, absolutely, it does.
And this is where you probably are catching me at a bad or good time, depending upon how you're feeling about this, like talking too much, whatever it is. I'm preparing my curriculum to try to teach 40 mid-career health leaders this stuff starting, my syllabus is due Friday. So I've been making slides and making up stories because I got to do the videos. Anyway, thank you. Sorry. Onward. So as you go forward, a few things to think about. I think the bill that came across, which is, I don't know whether any of you have had time to look at it yet. It's long, but there's a lot of great stuff in it. And I've got those strengths over there. I don't know why I had strengths of the bill twice, but what do you know when you're getting ready? So I do think there's some things to think about. I think primary responsibility should rest with one agency, which it it seems in two places it says different things, so you'll just have to figure that out. So one place it says Green Mountain Care Board, the other place it says AHS.
That about reference-based pricing?
No, it's just about oversight. So reference-based pricing, that, there are a lot of details in there that I don't think we should, I'm happy to answer questions, although I probably don't know them well enough because I only read it quickly over the weekend. I think you should, I mentioned these, think about independence, transparency, track record of meeting deadlines, because we have a lot to do to get the healthcare costs under control. You need tighter timing that's in the bill. Getting a healthcare plan out by 2029 is not going to solve our problems. And primary care is missing. And if I had my druthers, I'd put that in the planning and evaluation and have someone who's coming, whatever the planning and evaluation piece, come back with a proposal for single payer primary care and all payer primary care, universal affordable primary care, and just have them come to you with two great competing proposals.
Who's they?
Who's they?
Yeah.
Whoever it is. You guys decide. Whoever you decide.
Oh, you're talking about the regular agency. Okay, I got it.
If you're giving them a bunch of money, which you should, and
Okay.
is in the bill for planning and evaluation, one of their plans should be, how do we make universal primary care available in Vermont a year from now? Why not? Hire some consultants, get it done, come with two good proposals. You can reject them, but
And you think that should be in the bill?
I think so. You're asking the board to do all sorts of plans. What, a 2029 plan is much less useful from my perspective than a plan that would give everybody in Vermont universal primary care.
Gonna have a very long walk through a bill, I think.
What?
I said, we're gonna have a very long walk through of the bills.
That's good. So just some things.
See what's in.
So, but the elephant in the room is that we are facing a terrible crisis. We could lose Blue Cross Blue Shield. It risks insolvency. We are, lots of, several practices, FQHCs and others are threatened with closure. 5 hospitals, 6 hospitals are facing, worsening financial crises. And I think we should take advantage of this crisis to move much more quickly. To be prepared for what happens when the feds do something. And regardless of what they do, to start the work of taking costs out of the hospital and investing in primary care and improving access to specialty care, because that's going to be a virtuous cycle of strengthen primary care. Now you can get costs out of the hospital. Now we can improve access to specialty care. That's going to improve, it's going to be an engine that should save money. And allow us to strengthen primary care and give some back to the community through our reduced prices. So I think I know there is some discussions about emergency planning that are underway that you guys have probably heard about. Some meetings with the Green Mountain Care Board and AHS, and that is starting. That's really good. I think there should be a second track. I'm letting them I'm not just sharing this with you. If I'm a believer in improvement, why don't we start improvement now? How can we help these? How can we help? Could we get Peter Pronovost? Couldn't get Peter Pronovost to help coach us how to have every hospital participating in what he's doing in terms of quality? Learn, just pull whatever he's willing to share and implement it as widely as we can across the system, whether it's in primary care or otherwise. And then the question back to you: what are you going to do to help with those things? I think that's something that you'll have to be thinking about in the next couple of months. Because, if Medicaid collapses, if we have big Medicaid cuts, you'll want to figure out how to create an emergency fund or something that while you're gone, we don't have to get called back into special session. And whoever is trying to make decisions or that you trust can step in to keep from losing an essential service or essential organization. It shouldn't be a bailout for every hospital. It's got to be figured out. How do we convert those hospitals, some hospitals that need to be converted into the non-hospital hospitals that are still serving their communities? So that's, all right. My sermon, my great uncle was a preacher. Kind of honesty.
Any questions for Dr. Fisher?
I've exhausted you all.
I think this did well.
It's fantastic. Thank you.
Yeah,
Yes, excellent.
I actually think I have one question because, you know, there's this decision around who should be in charge of this. And in your slide back, you talked about independence, transparency, and accountability. And we have the Green Mountain Care Board, which was established over 10 years ago, 12 years ago, which is independent, transparent. I would say transparent. I'm not sure about the accountability. I'm not making any judgments on the accountability piece. So we have a primary regulator. And yet we're in this position where the system, Vermont's healthcare system, has not become more affordable. In fact, it's increased at much higher rates. So are we over-regulating? Are we under-regulating? And should we be providing the Green Mountain Care Board with even more authority, which this bill does? If they don't have a proven track record.
So I think it's a great, regulators are often captured by, it's a famous political science thing. Regulators can be captured by the interests they're regulating. Certificate of need has failed everywhere in the United States because hospital leaders all volunteer to be on the board. Or get the governor to appoint them. And I think, I've not been totally on top of the history of the Green Mountain Care Board, but I think the early years were essentially approving budgets as submitted. If I were to summarize what I understand of the record. And that started to change under new leadership, under Chairman Foster's leadership. I think it's fragile. We don't know. There'll be a new member of the board appointed. But the authority of the legislature to make sure the charges are clear and bring them back to see you when they're not. That is, the instructions are there. And I think that's not things like, no, we want to see healthcare costs flat, or, the target you should set should be as tight as possible. And you'll need to justify to us if it's anything above this, or I don't know, make it up. So, so the charge is clear. So whoever is the government, knows that that's what whoever the board members are, they know what their charge is. And improving the performance of this and give them a run chart. We have a run chart. We have that insurance prices, right?
Give them that and tell them here, get that.
I want you to turn this in another direction. We want it going down.
Leslie?
I think we do have a little bit of a case study on their accountability in Act 167, which many of us passed, or some of us in 22. They did their job. They hired the consultant. They put out a report that was extensive. Many people objected for political reasons, I'm going to say. And I think the politics of what goes on in state government and Green Mountain Care Board, it gets in the way. So how we move around that is a concern of mine. I don't know if you have any thoughts about it, but you're from an outsider.
I try to think about what are the principles you might think about for how to make decisions. I think you've highlighted this tension between the Agency for Human Services and the board. So I think this is an important topic for you all to be looking on in the remainder of the session. You have the great chance to take lots of feedback from multiple people. I think I don't think it's particularly I think if you look at the principles I've emphasized, independence, transparency, track record of meeting deadlines, vulnerability to political influence, I think you'd land. I think you know where I'm pointing. Without my having to say it and piss off my good friend Brendan. I don't know what that was. I don't know whether that was totally impolitic.
We like
Not
Brendan.
politically correct.
Not politically correct.
We're working for.
Brendan tries hard.
No, I think he's great. I think, and I see he understands a lot of this and is, you know, I think on the implementation side, of course, that can't be the Green Mountain Care Board doing stuff. The blueprint is an extraordinary resource. If you're thinking about primary care, there's what to build on. There's no question.
Well, thank you. Oh, I'm Leslie.
This was just a quick, you said talk to a lot of people, and if you had ideas about who else, that would be really interesting, or
That's
what.
a good question. I'll think about that.
Yeah,
I mean,
yeah.
Chris Kohler is, knows more about state health reform issues, and I'm sure he'd be willing. He might not drive back up here.
No, but we could.
But we could zoom him in. Chris is very thoughtful. He's curious about what's happening too. I got an email from him recently.
Good. If you could recommend anybody that you think that it would be helpful for us to talk to, because I'm sure we're going to be talking to lots of people.
Great. Let me think about it. Maybe that, you might think about what questions you're most curious about, or at least you want more, because then I may be able to help find people who would be willing to connect you with people if they don't answer your first email. Or I'm happy to reach out and people seem to still answer my emails.
Thank you. Thank you for coming to see us in person. Much appreciated.
It's always much more fun.
Appreciate you.
Thank you very much. Well, it was, of course, it's so much more fun to be with you than looking at another Zoom. Great. Thanks.
So we are going to pivot to our legislative council, who I have asked to have an amendment prepared for H80, which is, I'm not guiding anyone, but I'm anticipating that the committee will really, really enthusiastically be in favor of after our discussion last Friday. And also we'll take a straw poll on whether or not the committee recommends this amendment, and the opportunity for anyone who wishes in the committee to sign on to the amendments.
Yes.
Yes.
Mike Fisher.
Mike Fisher.
After listening to this great conversation on Friday, I reached out to the parties and before you solution to the.
You might want to run out for a drink right now.
Can I just say, when I'm on Zoom
No.
and people talk softly in the sides, you don't hear. I guess on YouTube, I don't know if you hear. Can you say that again louder?
Just that we heard you and reached out to the parties and put forward the language that Ledge Council put forward at the chair, and took us a little while, but here we are.
So it went through the rooms of lawyers that we heard about and it's okay.
Level heads.
Okay, thank
With a
you.
little time to think.
It went through our lawyers.
Well, thank you.
Hey, good afternoon, Jen Carby from the Office of Legislative Counsel. So I think we will first, because I paired the new amendment as an amendment to the amendment from Friday after consultation with the clerk's office about what would be next, but I did it without highlighting, so you would be ready to send it for the calendar if you decide, any of you, to pursue it. Let's start with what we looked at on Friday, which was putting that articulable nexus language in here instead of regarding. And so this was, again, in the context here is we're in the bill about the Office of the Healthcare Advocate. And this is in the provisions of the health insurance rate review statute that relate to what the healthcare advocate can do. And under existing law, the Office of the Healthcare Advocate can submit to the board in writing suggested questions regarding the filing for the board to provide to its contracting actuary. In the bill that you were looking at, they were making some changes to that to say that the questions would not just be suggested, but they would be questions regarding the filing that the board would ask the insurer either directly or through its contracting actuary, if any. The language that you looked at on Friday would change regarding to with an articulable nexus to the filing. That was the first instance. The second instance, which has not changed, would have this additional language saying around the Office of the Healthcare Advocate's access to confidential or proprietary information, saying provided nothing shall require a state agency to prescribe or disclose information prohibited from disclosure by state or federal law that would cause the provider or discloser to violate any statutory or common law privilege. So we had two instances of amendment. The first one on this rate review piece and the second one on access to confidential and proprietary information. So now we'll put up the.
Should I play a drum roll?
You like that.
I won't.
All right, so this is currently from the chair, but could it be expanded to include other members? And in this case, she moves to amend the report of the Committee on Healthcare by striking out the first instance of amendment in its entirety, so the one about rate review, and inserting in lieu thereof a new first instance of amendment as follows. So this one actually does a couple of things, so that's why I wanted us to look at the old one first. So the first thing it does is to change the language here to say that the office can submit questions with a substantial relationship to the rate filing as opposed to an articulable nexus. So questions with a substantial relationship to the rate filing and review criteria that had been part of the group's initial request and have gotten lost in the various emails I was getting. So substantial relationship to the rate filing and review criteria that the board shall ask the insurer either directly or through its contracting actuary. The other change in this section that you can't see because the word isn't here, but you may recall that it used to say the Green Mountain Care Board shall contemporaneously post on its website or otherwise make available all materials in the record. And the Green Mountain Care Board's general counsel asked to remove the word contemporaneously. So it has been removed, which is why you can't see it here on line 17. That's why I struck out the whole section 1 and not just the subdivision that we were originally amending in the amendment we looked at on Friday. And then that's it because we're not touching the second instance of amendment. So the second instance of amendment that the committee had voted out would continue to proceed, but you would effectively be substituting this new first instance for the first instance in the committee report. As the committee doesn't have the bill anymore, that's why it has to be done, proposed by individual members.
I think I have a procedural question. So we are amending the first instance of amendment with a new first instance of amendment.
That's right.
We are inserting a second instance of amendment, which is the removal of contemporaneously.
No, that's all going in your new first instance of amendment.
Going to the first
This is
instance.
all, yes, because it's
Okay.
all happening in section 1.
So we don't need to renumber the.
Don't need to, exactly.
And to,
Exactly.
and now a third.
Yep, that's what I talked to Betsy Ann about was various ways to approach. And so this way seemed the cleanest of just striking out all of section 1, putting in a new section 1 that says what you want it to say, and that wipes out the first instance of amendment.
Okay.
So we will want to coordinate with the clerk's office about just the order of what to expect as far as what gets offered and taken up when, just so that you're not surprised.
So we no longer have articulable nexus, which I am going to have to try to pronounce on the floor tomorrow, which should be hysterical, so.
You are not gonna have to, you don't have to.
You're right, I don't have to.
You should.
Anyone have any questions about it? Anybody want to, nope. Anyone anyone really wedded to articulable nexus? No.
I spent a lot of time this weekend practicing acceptance. However, I'm grateful. I wanted to suggest this and not, but then I didn't want to make trouble. So I'm grateful that it's happening because I think it addresses the concern of people not understanding it. I would like to be a co-sponsor.
Okay, would anyone else like to co-sponsor this?
Sure.
You should. It was your idea.
Is there anyone who does not want to be a co-sponsor on this?
Okay.
So the entire committee minus Representative Houghton?
Do you think she does or can she not? Because of
I'm not going to speak for her, but she's not here.
And this is, I mean, fairly often if there's an amendment that, something that comes up after the committee has voted the bill out that the committee wants to address, when you don't have jurisdiction, you don't have possession of the bill anymore. It's fairly common that most or all members are listed on as co-sponsors.
Yeah.
But that's, again, only if you're comfortable doing so.
Yeah. Okay. So I will take a straw poll on whether the committee recommends that. Yeah.
I just have one question. That the information that is confidential. Is it obtainable eventually?
Is it obtainable by?
Is it obtainable eventually by Mike?
Not, I mean, it depends on the circumstance. Sometimes there might be something that was, for example, a contract under negotiation might become public later, but would not be public, would be confidential while the contract was being negotiated. And there might be reasons that his office could or couldn't receive it. But if information was confidential because it was protected by HIPAA and there was no release from the patient to have that information shared, no, it would never become available. But I think there were concerns there. There are a number of confidentiality provisions throughout. We can't do anything about the ones in federal law. We couldn't waive those, but even of the ones in state law or privileges between an attorney and client, that people may have a certain expectation of privacy that may not extend to a nonprofit organization, nonprofit law firm that is under contract with the state to provide the healthcare advocate services. So without making that decision on all confidential and proprietary information that is currently prohibited by law and notwithstanding those, instead it's operating within the parameters of what is not otherwise prohibited from disclosure. And it's my understanding the office is comfortable with, the Office of Healthcare Advocate is comfortable with that.
All right, so I will take a straw poll on whether or not the committee recommends that that the bill should be amended as offered by Member Tomasic. Yeah. 10-01.
Okay, and so do I understand everybody would like to be on alphabetical after the chair, which I think is alphabetical anyway? Okay, great.
Pepper.
Oh, are we done with this one now?
I can assure you, we are done with this one.
Okay.
Unless, of course, anyone else
No,
offers
no,
an amendment on the floor tomorrow or before third reading. I can't speak for anyone else.
But I just want the committee to know that bill that I am going to do on the floor, I don't know when I'm gonna do it, probably Thursday now. There are some mistakes. And I found it out over the weekend while I was preparing for this thing. And I don't know what you want to do about it. I'll give you an example of a mistake.
Okay.
It says complete an exam in the bill.
Mhm.
It doesn't say pass it. It says complete.
Oh.
And I know the first question I'm gonna get asked is, what does that mean? So I looked in the definitions to see if there was anything, and there isn't, so. I don't know. I'm trying to figure out how to change that before we get there, so we don't have to deal with stupid questions.
Um, let's maybe meet with legislative council over any of the concerns and ensure that talk about the best way to proceed. Okay, I'm sorry, Daisy.
Your bill has rulemaking in it, right?
Yeah,
So a lot of the procedural things that are in that are gonna be addressed during rulemaking. So that would be a question I would want to ask Ledge Council is for a lot of that stuff. Can we indicate if anybody asks on the floor that it will be addressed in rulemaking?
yeah. I tried to draft it saying, I anticipated some questions, and I said, well, that will be done in rulemaking.
Right.
Yes, I
Well,
realized that it says complete and it doesn't say pass,
right.
but that's the rule of the board. They'll deal with that.
Mhm.
So anyway, I just wanted to let the committee know that we may get some questions that, or I will.
Brian and then Mari.
I like Alyssa's suggestion that that a small group meet with legislative council, and if legislative council thinks that it needs to change to address your concern, I would support you coming to us with an amendment for us to approve. We could do it the morning, like we can do that last minute, because that's how amendment, as you know, better than anyone. So, but I would support that. I appreciate that you found things that, and you're investigating.
Not many. I mean, it's just that, I think we did it so fast that.
And we may find out complete does mean pass. I don't know. I'm not putting Jen on the spot either. Yeah. Or,
Mari.
We do need to find time tomorrow morning to talk about likely amendments to H 259 and get make sure we have access to Ledge Council.
Yeah. I think that we will know by tomorrow morning whether or not we'll have amendments on that. And we'll find a time to hear those amendments.
Okay, I think they're probably likely.
Yeah, I'm looking.
Yeah, the workplace violence.
All right. I think we're all set for today. Thanks, everybody.
thank you.
I know it's been hot in this room.
So
It's beautiful. Are we all set?